Hello, everybody. Today we'll be just going over some of the main topics that we've discussed today in the internal medicine class. It's just pointing out two main topics. One of them, and the first that I would start with, is the main general questions that a physician should be asking when first exposed to meeting a patient, so that we are able to reach a proper diagnosis depending on the answers that we get from the patient that we meet. And the second thing that I'll be discussing is a couple of words, general diseases that we have gone over today in the class, and how we can reach to diagnose them using the questions that we are going to always stick to as physicians. So the first thing is, as I said, the questions. There's a couple of questions that we ask the patient to direct our conversation and make it as quick as possible when it comes to the first exposure. Because we have a lot of patients that are waiting for us. We don't want to waste a lot of time, as patients get or tend to talk a lot and speak about their personal experience. We don't have a lot of time on our hands, so we want to reach the proper diagnosis and provide the proper tests and treatments for all patients as soon as possible. And so these are the questions. The first one is the age, the profession of the patient. The third one is a life habit that the patient is used to, whether it comes to smoking. Here we ask if a patient smokes or not, and so if yes, for how many years, and the amount of cigarettes or smoking that they perform per day, whether it's a packet or more, if they consume alcohol, or if they even consume drugs. The BMI, we see and we look and we take an idea if the patient is thin or overweight. This gives an idea of what route the disease is going to be. The family history, here we focus on the close relatives of the patient, starting from the parents, going to the siblings, and then we dive into the real problems of the patient. And so here we ask, what is your complaint? And so the patient will start speaking about their problems and what they face, and they may start saying about the pain, talking about the pain. Here, as a doctor, you go ahead and say, okay, where is the pain located? And if there is any radiation of the pain, if it goes from the place that they point onto to another place in the body, and if the pain elevates when the patient performs their exercise, and then whether the pain declines in case the patient takes rest. And then we can perform some exams that include things like blood pressure, ECG, X-ray, ultrasound, and coronography. And then these questions and tests may help us reach the proper diagnosis of the patient. Okay, so the first case that we have been exposed to in the ward is pneumothorax. I didn't know what personally this was, so I just had to go in and research about it, but it's very interesting. Here, what pneumothorax is basically air in the chest. And so air would accumulate in the region between the pleuras of the lung. So the lung, as we remember, is covered or lies within a sac called the pleuras of the lungs. So they're made up of the parietal and the visceral pleura. The space between them is called the pleural space, and this is where the air leaks in. Usually the pleural space is made up of a negative pressure that is basically like a vacuum due to the effect of the pulling force of both the chest wall outwards and the collapsing normal effect of the lung. And so this negative pressure is basically the pleural space. And so If there is a leak in the air would go into the pleural space, and that would cause the negative pressure to decline. Hence, there's no negative pressure within the pleural space, and so the lung would collapse, as you can see here in the image that I've pointed towards. There's a couple of types of pneumothorax. Here, there's a spontaneous, the traumatic, and the tension. The spontaneous evolves from a problem within the lung itself, where a bullae is formed, where it's just a bump within the surface of the lung that is formed due to a leakage within an alveoli, and so air would accumulate until a bump is formed, and so pneumothorax would develop, and that's the spontaneous type. The second type is the traumatic, where let's say something pokes through the external covering of the wall of the lung, and so this is called the traumatic. Let's say a bullet or a knife. Here, pneumothorax evolves as well. Tension is similar to the first two, but here in this case, there's a valve system where air moves in, is not able to move out. So it's just a unidirectional movement of air into the lungs. And so the X-ray would show a collapsed lung, as you guys can see over here. The symptoms and diagnosis. And so if a patient comes in, of course, we ask them all the initial questions about themselves. And then we go into the pain questions, whether it elevates, whether it gets relieved. And so things that we can know that it's a pneumothorax disease, the answers of the patient would include chest pain. You can see shortness of breath. And so you can also test for the sounds by performing lung percussion. You're using the two fuck-off fingers. And I'll show you at the end of the lecture how these are performed. But what we'll usually hear for the pneumothorax patient is there is hyperresonance. The sound is a lot more than the normal. And so an X-ray can help us see all of these things clearly. And then treatment is usually using a needle or chest tube, which allows the air to escape. Okay, so that's the pneumothorax. The next thing we're going to speak about is the myocardial infarction. And so this is basically when part of the heart dies off. And so this is caused due to a blockage, I would say, in the coronary arteries that supplies the muscles of the heart with blood, oxygen, and nutrients for them to be able to perform and contract well, so that the heart can act as a functional unit to pump blood out to different parts of the body. And so how this is usually occurring is due to an initial atherosclerosis effect within the coronary arteries of the heart, and then part of the atherosclerosis is removed, and then a thrombus would evolve to cause a complete block of the coronary arteries of the heart. And so part of the heart would not receive blood, and hence cells start dying. And so a part of the muscle of the heart would also go into like a death state. It can lead to a chronic heart failure. So in order for us to diagnose this, we go about it the same way with all the questions. And so answers of the patient related to myocardial infarction would include having a crushing chest pain, and they would point at the heart that way. And sometimes, because the second question of yours would be, does it radiate from the chest to anywhere else? And if the patient says, okay, the left arm, it's a clear indication that there is a myocardial infarction. Shortness of breath, of course, because we are not able to deliver enough blood to the lungs. And so the lungs are not able to exchange blood, exchange oxygen, carbon dioxide really well, and so shortness of blood, of breath evolves, and this is another word for this is called dyspnea. Danger of duration, you can ask the patient how long this took. They say more than 20 minutes, then this is a good sign to say that this is a myocardial infarction. And then you can see dizziness, vomiting, and nausea, and these differ between females and males. In males, they are seen less. In females, they are seen more. And so tests that are used here to make sure that what we have is a myocardial infarction is basically ECG and blood work. ECG can be performed, and trends of the ECG can be compared to the normal ECG. So a myocardial infarction is made up of two types, STEMI and NSTEMI. The STEMI is or an NSTEMI, both are a very good indication that this person has a myocardial infarction. So if you can see here that the normal ECG looks like that, where the ST segment is what we focus on. In a STEMI, a myocardial infarction, we see that the ST segment is elevated, or a different type. Now, ST is basically a where there is a huge part of the wall of the heart is affected. And so this is the STEMI, and NSTEMI is a smaller part of the heart that is affected. And so it may be seen in two ways. The ST segment of the ECG is depressed, or the T segment is inverted. And so NSTEMI and STEMI, both of them show us signs of myocardial infarction. The long form of STEMI is basically ST elevated myocardial infarction. Okay, and the third thing we can do is blood work. And so blood work is basically we are testing for troponin T and I. These are components of the intracellular part of the cardiac cells. And so when infarction happens in the heart, the heart cells basically rupture, and so troponin T and I is released into the bloodstream. Testing for troponin T and I tells us that there is a myocardial infarction. So three things that should be done, as I said: questioning the patient, ECG, and blood work. And those three are, if they all hold positive, then we know that there is a myocardial infarction. Okay. And then there's the pulmonary embolism. Basically, what this is a blockage of a part of the pulmonary artery leading to the lungs. And so there's a blockage because of an embolism that originated from the thrombus that was in the vein. So a deep vein thrombus is a source of an embolus that traveled from, let's say, the lymphs all over to the heart, pumped into the pulmonary circulation to go to the lungs. And so a blockage, as you can see here, has evolved. And so what we can see or have answers from the patient include, dyspnea, shortness of breath, unilateral chest pain, one side of the chest hurts, tachycardia, hypotension due to dilated pulmonary vessels, and of course, X-ray is performed. And these here are some signs of, pulmonary embolism that can help us, confirm that this patient has a part of their pulmonary circulation blocked. delivering the blood to the lungs. And so we can see that on X-ray, we can actually see that the pulmonary circulation within one of the lungs that is blocked does not function well. And so the lung doesn't receive enough blood and perform its function of exchanging oxygen and carbon dioxide. And then final thing that we've seen in the first internal medical class, it was the limb ischemia, where one of the patients had literally both of their feet colored, very darkly like that. This is because the doctor mentioned that this patient was given a norepinephrine dose, and so norepinephrine causes constriction of some of the small vessels, and so in this case the patient was exposed to that in his feet, and so both the feet looked like that when we examined the patient. And so we were told that the limbs would be partially removed without their toes, and this was also part of why people shouldn't smoke, because smoking led to such a thing within this patient. And in this case, it was a pack per day. The patient was about 60 years old and have smoked for over 30 years. And so it's a very dangerous thing to smoke. So if you're smoking, please rethink about your health and not evolving limb ischemia. All right, thank you very much for joining in, and I'll see you guys in the next video.